Thanks, James. That's a great, heartwarming story, and thanks for sharing with us. Like the term "professional patient," that I'm going to start using that. I've seen it before, but yeah, that's a great term. With that, we'll open up for questions, and as we open up for questions, and we're looking at the chat, I can start one for each answer real quick. One of the things that there we go. We'll restart. Okay. One of the things as we're looking in the chat, and if you're online, please add some questions. If you're in the audience and you have a question, go ahead and raise your hand and we can bring a microphone to you. But one question I'll start with as we're waiting for those is, transition's really challenging. There's also many different perspectives, different stakeholders in the process. And I wonder if you guys could each comment, and maybe we'll start with Dr. Ehrenberger since she's furthest down and work down the line, of if you were to say what a good transition looks like, what does a good transition look like from each of your different perspectives? If you were to define a good transition, what would that look like from your specific perspective as an adult provider, as a pediatric provider, and then of course, most importantly, as a patient?
I think from my perspective as an adult PCP, a good transition really involves good communication. Because we take very seriously the responsibility that we have for our patients. And so I dislike surprises. I really am looking for the pediatric PCP or specialist to let me know what the young person's major issues are so that I know what I'm walking into the room with. Sometimes I have to do my research before I meet them because we do take care of individuals with every kind of condition. And so it's just like nice to know beforehand so that we can meet together and make some goals and reach them.
I definitely agree with communication. What I would add to that is engagement for all the stakeholders. So when we look at the team, I need to know that all my team understands that it's time to be thinking about transition with this 13-year-old and move them along, because we have to have a solid approach, a unified approach when we talk about transition with our patients. We have to have engagement of the family that this will work. And sometimes that first, with the introduction, as I mentioned in my presentation, is a little bit rocky, but the parent caregiver has to accept that that's part of their child growing up. And then the teen has to engage. And I think that's probably what makes, when I think of my patients who've done this very successfully, and I have some patients now that were enrolled when they were about 14 and they're hitting that 18-year-old period now with being in our program, and they really engaged nicely, and it makes each of these sessions flow so beautifully. And then certainly engagement of the adult provider and their team so that it's not like, oh, well, they're sending us our problems, which actually we don't hear about anymore. That used to be the biggest problem with the adult side, like you just want to get rid of them. But I think the adult side has done a great job in all the hospitals that I've been dealing with about understanding that they need to accept this. There needs to be a willingness. So I need those adult people to be engaged where the young adult is at that time, which might not be perfect, but how can we do that overlap? So I'd add engagement to communication.
We have to, as a patient, know a little bit of what is wrong with us, actively listen to our physicians. I like to look up everything about my health. I like to know what the words are, so I'm sitting there and the doctors are talking, okay, I know what that means. I could follow along here. Like I said earlier, be a professional about what is wrong with you, be part of the team, listen, and be able to relay to your physicians what you're feeling, what's going on in here, what's going on in here, and what you feel you need to get you to hear. All relationships need communication, whether it's your marriage, your doctors, or coworkers. Listen.
While we wait for questions from the audience, I have a question to the panel. Like it's about resources for the transition program. It's quite resource intensive, but in this current reimbursement environment, it is not
actually a reimbursable service. So how do we reconcile the difference at our level and also at the policy level?
To a certain extent, we are victims of our own success. I think what we're seeing now is a generation of young people who have survived the NICU, they've survived the PICU, and now they're coming up into adult medicine. And so, on the one hand, I think as a society, we have this idea that all babies are born and they grow up and they become independent adults as a society. And this isn't true, because there are some people who are going to need more help than others. And rather than putting the onus on the growing young adult to be able to coordinate all of their care, I think our various medical societies are really going to have to work together to make this a policy priority so that people aren't left in the lurch and in the gaps, because this is a matter of life and death.
Yeah, I agree with that, and I was going to say the same thing. I think that's where our organizations for our specific conditions come into effect. And I think that when we do position papers, white papers, that when we are talking about our outcomes, like we know there's plenty of literature right now, particularly in kidney literature, where that gap between pediatric and adult care has an increase of up to 20% mortality in that group, that they don't make their first appointment after transfer, or their first time they see a physician is in the ER, not because they broke their leg playing softball, but because they're jaundiced and their friend said, you should go check that. So I think our organizations can set up standards, and then, for instance, like CMS in transplant, the Center for Medicaid Services mandates that all of our patients have a social worker assessment and a psychology assessment pre-transplant and post-transplant. So similarly, I know that the United Network for Organ Sharing is working on a transition policy. So I think when they see that this is important for good outcomes, then this will be mandated too. Just like I think we all owe our transition programs to the pulmonology people, because years ago, I think somebody correct me, I'm not sure the exact organization, but I want to say the American Lung Association said that they wouldn't accredit hospitals in providing care for cystic fibrosis patients until they had a documented transition program. And that all started at the University of Wisconsin. And in our group at AST, we worked with the University of Wisconsin people from their cystic fibrosis template to develop what we did. So I think when it's mandated, that'll help us get the resources that we really need to make this a comprehensive program.
I can ask another question for each of our panelists real quick. Bev, in your talk, one of the things you said was it's important for people just to at least do something. And I would say, doing something is picking about that one next step you're going to do. I always think of transition being about a journey, and a journey is thinking about where we're going for a destination. We have to do step after step. I love these different perspectives of communication being really important, engagement, and then the professional patient. So really about being independent or interdependent. If from each of your perspectives, what would be just one step that we could take to help think about making transition better? If you were just to say there's just one thing from your perspective as an adult, pediatric, or as a patient that would help with this transition process, what's one step to take?
One step from the patient is I wish I would have had a roadmap of where I actually wanted to be in life. You can go to college. You still got to go to your doctor appointments, but you could go to college. You don't have to get doctor's notes for not doing certain things. You should plan, I'm going to do this. I want to, I can. And have a roadmap like that medically as well. To get here, I have to see my doctors, I have to do my blood work, I have to follow up and know what's going on. Then I'll go to class, and then I'll reach my goals.
I would agree with that. I think it's the communication that I would start with, and that's kind of how our program started, that we would just discuss it, like, what do you think you're going to do, and talk about that. I like your idea of a roadmap, and there are some tools out there for that with the gut transition. But to just talk about it and think about the plan, because a lot of my young adults aren't thinking past a certain point. So how do you push them to think about it. So I would just, again, talk about it.
It's not only the young adults who aren't thinking about it, because I will not infrequently receive somebody in primary care. They may be 21 because their pediatrician will no longer see them, and their specialists have not talked to them about transition yet. So if the specialist isn't going to bring it up, then the caregiver or the patient needs to just ask, how long are you going to see me? When should I think about going to an adult provider? Do you know somebody on the adult side that maybe I could see?
Thanks.
Thanks. So I am a CF doc, so it was the Cystic Fibrosis Foundation who really pushed this. And they said, you need an accredited adult center or we're not going to accredit you, period, if not 90% of your patients by age 21 aren't transitioned appropriately. And I think that's wonderful. And I think that that mandate really did push health systems and institutions to do that work in getting things set up and resourced. And the CF Foundation further doubled down, and they give resources to our programs where we have social workers and a multidisciplinary team that are funded externally from our hospital by the foundation. I think my question is, for disease states or chronic conditions that don't have an advocacy association that is that well funded and that forward thinking, how do we as an institution really move the bar forward without waiting for these disease mandates? And I think that my question is, kind of piggybacking onto yours, Andy, what resources in the ideal world would you like to do this work the best that our patients and families need?
Wow. I agree with you. I think that if you do have an organization, it certainly helps, and at least you're starting somewhere. So for those that don't, is there someplace you could partner with, or is that where our hospital becomes very important? So we need to have, and I know we're working on that in our task force, where we have a uniform policy for the hospital. And so how can we launch that within our hospital so that the other groups are also accounted for? And we're also working with that with the transition services that we're starting with, the medical department. I forget which department's starting that. For the consults for transition. Adolescent medicine is starting. So I think that when they fall between the cracks, then we have to have the hospital there to be guiding that.
Yeah, no, you're exactly right, Bev, because it's in the interest of, in this case, Children's Hospital of Pittsburgh, that their young adult patients move on to adult care to make space in those beds for the younger patients, as well as to ensure that they're getting the care for their stage in life, for those adult problems and those adult bodies.
And so this may just be a teen that happens to be in the hospital for whatever reason. It might not be a serious chronic condition where they would fall into the cracks, so to speak, but it's still important that you contact that teen when they're in the hospital. So this consult service will be really important for them, because everybody needs help. Like, for a young woman, when do you first start going to see a gynecologist? How do I get a PCP? I mean, I think that's one of the trickiest tasks. I think Kristen brought that up. One of the trickiest tasks for my patients is finding a PCP. We have the specialist doctor, but I need good internal medicine people to follow my patient comprehensively.
And would I be able to just make one quick comment also based on Tracy's question there of how do we do, I would say culture shift is really what we're looking at. And I think there's two really important things. I think Bev talked about this in her talk, policy statements, right? As an institution, policy statements sound very boring, but it means that an institution has created a stance that they are going to invest in a specific area. And for UPMC or a hospital system to have a true policy statement around what transition, it doubles down and says, we are investing in that. So that's an important thing. The second thing is that I think that there are too many silos, and we have to think about how do we break down the silo of the hospital system and the community, right? Often we think about these in different areas, and what happens is we start kind of coming from an angle of how do we do work on a community rather than with the community, right? And so we need to figure out how can we make this a bigger conversation where we're all working together, because the reality is, I'll just give a shout out to the Down syndrome community. That's where I work. The only reason why I have a transition clinic is because the Down Syndrome Association of Pittsburgh, which is a family-based nonprofit, funds our clinic so that I can spend up to 2 hours with the family. That's the amount of time you need to really do transition well. You need time, you need those resources. And it's really that partnership of the hospital and the community that makes that work. And we have to figure out how to do that better, so that we can actually make a better system for everybody. Because the reality is there are going to be people in groups that they don't fit a specific area. They don't fit a specific clinic, but if we build this together as a community, then we can actually help everybody. So I think it's really important that our hospital kind of creates a policy that they double down and say they're investing, and then we need to break down silos. We need to be able to work in combination with our communities to be successful.
Yeah, thanks. I think we have time for one last question. One of the questions posted was, when does the process of transition start, and at what age? And I'll answer with my perspective before I ask the panelists. This can start even before birth. We are making a diagnosis of, for example, congenital heart disease in utero. So, and the counseling that this is a lifelong condition and it is treatable, but you do need to transition into adulthood. So that's kind of like a philosophical answer that it can start at any point, but I'll open up to you guys to see if that's the right answer.
I think adolescence, 11, 12 years old, when you're really becoming your own person, and once that little bit of puberty starts to set in and you're becoming your own person, that would be an absolute great time to start transitioning a patient to taking over their own care. I mean, they're going to have to start doing their own homework. They're no longer in elementary school. It really is a great chance to do it all in that step. Young, you can do it little by little when you're 11, 12. Then by the time you graduate high school, you should be a fully functional adult, ready to go on your own. At 7 years is very important, I think.
Our program, as I said in my talk, officially starts at 13 when we give them the policy and we start them, but we talk about it before that. So when we're evaluating a new, a 6-month-old with biliary atresia for liver transplant, or a year-old patient with gastroschisis for intestine transplant, that is part of our evaluation process. So we do a full educational session with a PowerPoint program, and they see a slide about transition and what that's about. And in some cases, it's almost encouraged, it's a positive thing, because some of these parents are worried that their child won't reach puberty, won't be 13 to transition. So that's often, it's interesting when I do that with some families, that's when I see the tears, because they see hope that after transplant, their child will have a longer term survival. And I will have to worry about those teenage things. I mean, they kind of want to, it's a good thing. So officially, but we start earlier. And then it's also, I didn't do this in my talk, I mean, there's so many things to talk about with this, but for our patients that are in the hospital, and for those of you out there that are in the hospital, it's important to still be that advocate when you are there and to know what's going on with your care. And for the nurses, and this is another area I need to do a little more work on, when they have a 15-year-old patient that they're going in and asking them what are these meds that I'm giving you today? When do you take them? What do you worry about with the medications? So that from all the systems around, even when they're like 11, 12, 13, that we are still addressing transition with them.
Yep. Thank you very much. With that, we'll wrap up this session. Those are fantastic talks. Thank you, everyone. And just a couple of announcements. We're going to be taking about a 10-minute break and reconvening at around 10:30 or at 10:30. And those will be breakout sessions. For the online audience, you should have received links, and it's also posted in the chat. If you want to do the first session, sexuality, contraception, and reproduction, you stay on the main Zoom link and in this room. And the Other two will be in the other links posted, or you shall receive those through your email as well. Thank you. And we'll reconvene at 10:30.